So you said you started in this type of practice 18 years ago. I'm sure you've seen some roadblocks that you've had to get over in the course of your career. Could you share some of the barriers to becoming involved in integrated care?
Yeah, it's funny. When I first sat down with this primary care practice that I work with, it's North Willow Grove Family Medicine. They said to me, I said, "Do we get any brownie points for saving all your literature for all the years that you came to us and say, can we do this? Are we ready for integrated mental health, or can we do collaborative care?" And they pulled out old brochures and old files that I had sent to them about how to refer to me and how to integrate me into their practice. So the key thing I have to address the fact that reimbursement prevented me from working in other settings outside of an office. My setting was only that address that I was allowed to work in. I wasn't allowed to work in alternative settings. When I contract with the insurance companies, they say, we need to make sure we inspect your site. We need to make sure that certain things are met as far as documentation and safety of documentation. So the credentialing process actually was, at that point in time, very rigid about making sure that I practiced only where they allowed me to. So the place of work had to change, and then that affected my ability to reimburse. The reimbursement codes were bad. They only said that I'd be able to reimburse for, and they still do this now, many of the companies say, we will only reimburse you for a psychiatric evaluation or psychotherapy codes and not these behavioral health codes. Behavioral health codes reimburse at a much less quality than my E&M codes that I'm now able to use as an APRN in these settings. Reimbursement is still not congruent, and it still remains a barrier, and I do not get what my cohorts do, my NP cohorts do in the primary care environment. So reimbursement systems are still a major problem with getting to moving on to the better place for making sure that this is more cost effective. So we have that as a major barrier, and we're getting closer to moving on beyond that. But because they're also talking about other kinds of reimbursement, other models of reimbursement, and making sure that the consultation time can also then get reimbursed. So there's a call for a change from a fee-for-service system to a capitated contracts, or to even purchase of services, which is a different kind of funding, which I won't go into at this point. But there's different types of funding that they're looking at, and most psychologists are really looking at this first and foremost more than us. And one of the problems with, as I mentioned, with the BSNs have not been able to get reimbursed at all, and they certainly can't provide independent care that an APRN, most of us can. But the BSNs do not get reimbursed at all, even though they're licensed. Or any of the other master's level, bachelor's level healthcare professionals aren't getting reimbursed for their care either. So that's really a key thing that has to get addressed. We have to demonstrate more that we are cost effective in order to make these changes, and then we have to do more research about that and see what would be better as far as which direction we're going in. The second barrier is a reduction in workforce. And we're noticing that psychiatrists are aging out. So the shrinks are shrinking, and they're not replacing themselves. And as much as we still need them, and we're not trying to replace them, and they're dwindling. Okay, and it's very distressing because we need them for collaboration agreements, and we need them for higher levels of care that we don't provide or have yet to provide. We would rather refer for certain things, like ECT. And so we're facing the psychiatrist aging out. We also have major changes in increased demand. When you provide mental health in primary care offices, you will notice that there is a huge demand for your services, and then you won't have enough time to do anything. And there's increased documentation needs, and a lot of people don't want to do that. So that there's dissatisfaction with the profession. There's a lot of things that we have to understand as far as the new nomenclature and the codes, and we're also aging out. So making changes are going to be very difficult. And the third point is, well, APRNs lack public and professional awareness we're not doing ourselves any service unless we get out there and have a voice and demonstrate that advanced practice nurses there is a psychiatric mental health advanced practice nurse. And creating that awareness will also then allow us to campaign for better reimbursement, campaign for other things. Other psychiatric nurses do not even see the option. A lot of the advanced practice degrees, and we are invisible in many of their communities. So we really need to be able to be more populated. The cost of education for the Psych CNS to go back and get the extra classes is still high. A lot of us were intimidated by that climb to the next step with the LACE proposed, and we do need the educational funding because a lot of us could not go back to school. So we really need to say that if you want to increase psychiatry penetration in our communities, please look at your clinical nurse specialists going back to school for those extra classes so that they can become your next providers. It's a lot shorter than psychologists gaining that knowledge or anybody else. So taking a look at the role that we can play in advocating for grants for psychiatric nurses. The next area that I encountered as far as a barrier is collaboration agreements with psychiatry. And this is something which I'm sure that a lot of us talk about, but we don't necessarily publish anything about it or deal with it, but it's been on the member bridge a lot. Most states require supervision or collaboration agreements between psychiatrists and psychiatric nurse practitioners. And the psychiatrists in general are less than enthusiastic to become our collaborating psychiatrists because they see their liability as being increased when it actually decreases their liability because it provides better level of care, and in working in a team, it actually provides more access. So, they don't understand that, and they still are stuck on their safety issues when we actually have demonstrated that our safety is pretty insured, and we have professional standards as well. We need a clear statement about this. We need a statement from our legal resources. I was able to provide some statements to the collaborating psychiatrists to get good collaboration agreements in place. I was able to demonstrate my skills to the primary care, my collaborating psychiatrists in a variety of ways. But not everybody who I hired as an NP to work with me was able to demonstrate that. So it's very important that the trust be demonstrated before a doctor signs on as a collaborating psychiatrist. And then we have to make more of a statement about what we need to do as far as how to collaborate. And I think that was a barrier that I had in expanding. And this is something the Institute of Medicine identified as one of the barriers. So the last barrier to practice has to do with the Medicaid and the federal employees contracts. And this is something I brought up earlier. Most states have the federal employee contracts deleting us. They only cover psychologists, psychiatrists, and maybe social workers, depending on which state or what contract it is. They don't include psychiatric nurses as independent credential providers. And this is also true with Medicaid. And that's why we don't have Medicaid contracts as independent providers. So we have to go through other foundations and work underneath somebody for a Medicaid contract. What are they afraid of? They don't reimburse that much. It's not like we're going to steal the bank. Providing, a lot of these are block grants that they want to make sure they go to nonprofit funds. We can own a nonprofit. So, it is limiting. And I think that that's the last barrier to practice that I can think of, and that was identified by the Institute of Medicine. So that was key.
Okay, thank you for sharing your thoughts about barriers to nurses taking their role in an integrated care model. I think as the Affordable Care Act is rolled out and we revolutionize healthcare in the United States, I'm saying that hopefully, we'll have more and more support for the work of registered nurses and advanced practice registered nurses, especially in psychiatric nursing. Could you talk a little bit about the supports that we have for developing a practice such as yours?
Yes, that's very key. We were best at supporting each other Okay, the number one support that I received throughout the whole 25 years that I've worked in psychiatric nursing, 29 years of working in psychiatric nursing, was other psychiatric advanced practice nurses talking to me, encouraging each other through a variety of things. It was through these connections with other psychiatric nurses that I was able to then perpetuate the process that I was in, pursuing integrated mental health and collaborative care. And without the organization of American Psychiatric Nursing Association and other organizations, I never would have continued that pursuit. Even presenting on a state or national level, it actually continues the conversation, even though we were blocked on a commercial side. It also encouraged people who are continuing to work on the clinic side, the federal qualified healthcare clinics, to understand what the vision was from other providers that weren't necessarily actively working in it, but knew a lot more about how to do it. I couldn't go backwards and go into a federal qualified healthcare center because I had my own practice and I wasn't going to go there. I couldn't. But I was able to share that knowledge, and that perpetuated our ability to say that we were in that field. I also want to briefly mention there are significant people that helped provide that support. Nancy Hanrahan, who's a professor of nursing over at Penn, University of Pennsylvania, she did a lot of research about the workforce development and healthcare implementation and models of healthcare, and my conversations with her were probably the most progressive conversations that perpetuated into developing the mindful care model. Gail Stern, who was one of our board members until this past year, she was an executive director of a department of psychiatry that was developing a hospital-based integrated healthcare center practice. And she employed psychiatric nurses and was able to share knowledge over the years and her obstacles as well as what they were doing to help perpetuate this. And the last person who really perpetuated it was Nick Croce, and he dedicated his knowledge of connections of key people and how we could mentor each other through the process. And without him, other executive directors couldn't have done that. But without him remembering who did what and connecting the dots and connecting the people, and also incorporating a member bridge, we never would have been able to connect. So I think that APNA really deserves a lot of credit for this process. Insurance companies were blocking this. They actually had to work within their own parameters. And actually, 2 major insurance companies reached out to me over the years consistently, and that was Aetna as well as Magellan, to try to help perpetuate this to a higher level, but they also blocked it because they said, well, you can't go any further. We can't change everything overnight. We will have to wait until next year. Put it back on the shelf. We'll get back to it. So that they did help in some ways, but they also saw where their obstacles were within their companies, and they really did try, but they really couldn't help me much further than that. But in general, the other organizations that do help support other people and bring together multidisciplines of mental health providers. One is the Collaborative Family Healthcare Association, and I became involved with them at the very beginning, and Margaret Catronio, one of our psychiatric nursing professor that I knew, was one of the founding members, and they've always incorporated nursing into their vision and encouraged nurses to be involved. The next organization that really perpetuates healthcare is the National Council of Behavioral Health, and we need a voice in this company. I need to make sure that I don't know who is in there that works with it, but that's the key place where healthcare policy is developed, and they were the voice that was behind what was adapted in the Affordability Care Act. And the last organization that I take my hat off to, and I encourage everyone to visit this website, is Sansas. Sansas put together a perfect website that will be a great resource to anybody who wants to develop integrated healthcare. And it addresses all the models, all the solutions that have been out there, all the white papers that have been developed. They're published on that website, and multiple different layers of training and webinars and other things that are available. And that is a great resource for everyone.
Okay. Excellent. Thanks so much for sharing those resources with us. I highly encourage people to, if you're a psychiatric nurse, become involved in the American Psychiatric Nurses Association. If you're not a psychiatric nurse, your professional organization is a great place to start if you're interested in hanging out a shingle or setting up a practice similar to what Sharon has done. As we conclude this policy forum, I wonder, Sharon, if you've got some comments regarding the future direction of integrated care.
Well, I think we have to start the conversation. We are part of this. I think by having this webinar, we are starting the conversation. I think we need to find and share grant opportunities and funding strategies for development of a workforce and demonstration grants and other kinds of grants that are available so that we can not necessarily compete with each other, but so that we can join together and do a national demonstration of other kinds of models that are out there and demonstrate and talk about our role. And I think that that would be welcome. I also think that we should develop position statements. I put out there about the BSN or the Associate's Degree Psychiatric Nurse. They're licensed professionals, but they have a valuable role in monitoring it and patient education and delivery of integrated healthcare services, but they're not reflected in the roles that are currently available. And I also think that we need to develop policy statements, which we have already in some ways, about the integrated healthcare role of the advanced practice nurse, but we also need to update a lot of the things to include lifespan and our holistic ability to use vitamins as well as psychotherapeutic interventions. I think that that direction is very important. I also think we have to join, as an organization, join the National Council of Behavioral Health and participate in conversations about reimbursement and policy reform and identify clinicians within APNA that have that involvement and continue to connect us so that we have more of a council of integrated healthcare. So we discuss what we can do as a group of people, share ideas, share directions. I also think that we need to look at what we do in chronic medical conditions and actually discuss psychotherapeutic nursing techniques, both holistic as well as psychotherapeutic and psychopharmacology. And I just want to put out some examples: diabetes management, depression management, and how diabetes and cardiovascular and chronic pain impacts patient coping with depression, with their illness, with a variety of family issues. I also think that we should address anxiety and how it's displayed in irritable bowel syndrome, somatic obsessions, migraines and headaches, among others, obsessive tendencies. And finally, I think that we need to take a look at our momentum. I think we need to use what we have or we will lose it. We are a small profession in comparison to other nursing professions. If we don't stand up and become psychiatric nurses in a public domain, they will only see us as being inpatient hospital, and we will lose what momentum we possibly can capitalize on that have been demonstrated through the future of nursing. We now have the ACA as a law. People can't change that very easily. They've tried. We need to demonstrate it to keep it viable. We need to use nursing as a role that we play, that we actually function in. And unless we demonstrate the process of psychiatric nursing in our own committees, we will be invisible. And I think that's my main purpose is in my community is not to be invisible, and I'm not. So that's where I have to stay.
Well, thank you so much, Sharon. I've heard so much about you, and I certainly know that you are not invisible, and quite visible in your community and in psychiatric nursing. I know you've got a busy practice, and this was time hopefully well spent for you, and I certainly believe that it was for us. I expect someday you'll hear from someone that listened to this webinar or saw this webinar, and they'll say, I started my practice because of your presentation. I believe that that will certainly happen. The policy forum that was presented today will hopefully be a regular feature of the American Psychiatric Nurses Association, and we look forward to future presentations. Again, thank you so much for your time today, Sharon.